We've talked lots about the technicalities of STEMI and hospital procedures and policies and whatnot. And there's one of the things that we really haven't talked about. You can learn all this stuff. You can get very good at it. You can get it right most of the time. But if you hadn't got somebody who actually was a good teacher, bothered to take the time to teach you as an individual, the rest of this stuff just really, it's never going to happen for you. And at the hospital that is in our local area, the University of Virginia, about 30 years ago, they had the foresight to realize that they needed to do some education for pre-hospital providers, and they dedicated a whole section of people to actually do that. So they were quite ahead of the curve in their time. And, you know, tonight as we go through things, I get in a lot of trouble in life, and tonight I'm going to get in an awful lot of trouble because we're going to recognize somebody that we all think an awful lot of and who's been there right from the very start when that program started 30-some years ago. We were talking the other night, and there's probably several thousand people who have had their initial advanced life support training through that program, and I think is not anywhere nearly well recognized for the amount of work that she's done. And it's probably the last time she'll ever talk to me. Donna Burns, here you go. Stand up and be seen. There you go. We've been we're not finished with you. You got to stand back up again. We've been plotting and planning this for quite a while, and we're very appreciative of this. I'm very appreciative because you put up with me, and in some way you're sort of to blame for me doing this. So either way, it could be good or bad. This program started, like I say, about 30 years ago, and over the time that that program has been going, she's had partners. And the partners have come and go. They've come and gone, should I say. But over the years, Donna has been sort of the rock that's always been in that program. The first partner I've ever met, Dana Rockwell. Stand up, Dana. Dana was the original partner that I met, and then followed by Lewis Jenkins in the back. Folks, say hi and show some appreciation for these folks here. What we're going to do right now is we're going to go on with David Burt, and we're going to do the STEMI Showdown. Dr. Burt, all yours.
Thank you, Tom. How are we doing tonight? Good. All right, so this is a little bit of an experiment. We've got you guys, we've got our program, and so we're going to run through a few cases, and we call this STEMI Showdown. And you all have a clicker, and every time we have a case, you get a chance to put in an answer. And so our objectives today are fairly simple. We want to have a little fun. We want to do some STEMI cases. You want to beat your enemies, support your friends, and most of all, the reason we're doing this here is because sometime down the road, when you have a patient and they have symptoms and you do a 12-lead and actually have a STEMI, then as we were talking about earlier tonight, it actually might be your chance to save grandma, right? So let's keep that in mind. So there's not a lot of rules. So today, if we give you some history, great. If not, just assume it's something that could be cardiac ischemia. If we don't give you any past medical history, don't worry about it. Remember, time is muscle. You might have 15 seconds or 10 seconds, but you got to make a choice, right? And really, your responses today are it's a STEMI, it's not a STEMI, it's not a STEMI but something otherwise bad, or the choice that's not on here but we put in, I'm not sure, right? So we're going to give you a little out factor. So let's do some showdown. So number one, 82-year-old female. She's got a history of some stones, a little bit of AFib. She's your typical Virginian. Wants to support the local industry. She's still smoking her Camels. Here she is. Take a look at the ECG. Bad or not? STEMI or not? What do you think? You have 7, 6, 5, 4, 3, 2. Make a decision. All right. 96% say STEMI. Anybody want to take a stab at where it's at? So, yeah, anterior. What part of the heart does the anterior reflect? Front. And the front of your heart, what ventricle is that? Left ventricle. So left ventricle, you don't have a left ventricle, what do you have? Yeah, you got a funeral, right? So actually this lesion at 30 days, 50% of the people who aren't treated with this will die. Case 4395, 32-year-old rigorous bike marathoner collapses while training. So what are the odds that a 32-year-old marathoner is going to have a STEMI? Maybe not over the law of averages, right? But it can happen to everyone. So this guy's out running, fit as a fiddle, come upon the scene, and what do you got? 32. The whole thing. Yep. All right. So 73%, 14%. Got a I'm not sure, that's okay, and other urgent. Anybody want to take a stab? Okay, could be maybe an inferior, something going on inferior. Yeah, take a look. We actually have anterior, but also look out to the sides. How many of you noticed a lateral infarct going on? I see some nods out there. So if you have lateral and anterior elevation, what does that say about the lesion? Yeah, left main. Widowmaker, right? Okay. Male, 59, chest pain, the night before. Look. How many 59-year-olds do you transport with chest pain? Yeah, per hour. On a Friday night. All right. So, what do you guys think? Okay, so the PVC, right? So not a STEMI. Okay. Yeah. So I set you guys up. So this is a very challenging case, right? You can see if you look over at this patient's ECG, you start to see a little bit of elevation. Here in one, there's a little bit in over here, and then an AVF. And then you also see a reciprocal change in AVL. Now this is actually a very early ECG on this patient, and they actually did not activate on this patient. They brought him to the ED, and guess what they did 20 minutes later in the ED? Got another 12 lead. It was worse. The patient looked bad. Punched the button. It was a Sunday night. They pulled the CAT team in, and the patient had 100% lesion.
So here's a particular case, and we were talking, I don't think there's anybody in the room who thinks that this is a good thing to have. All right, very good. But we talked earlier on when we were doing the discussion about the difference that doing the right thing, doing it quickly, having a fairly low suspicion rate for doing 12 leads and taking care of people. And obviously this is STEMI versus no STEMI is not really the issue with this particular one. This is a patient that we all know fairly well. And this patient presents in bed, and not to put too subtle a point on it, dead as 4 o'clock yesterday. How's that for a clinical term? All right, because this is VFib. So the second case, if you'll go backwards, so to speak, is after some very prolonged aggressive resuscitation efforts. There was a lot of effort put into this. This is a case that really, honest to God, if you see them, these are the ones that you see 24, 48 hours later, they don't survive. They succumb. This patient spent an awful long time in arrest. So the interesting thing, and we promised you that we'd show you some interesting people. So if you all follow me back here a second, Sharon, stand up. This is you. You didn't know this was you, but this is you. All right. So this is Sharon Morton, who's one of our good friends that we see a lot of the time. So if you have no doubt ever that doing this right and spending some time to learn it, this is why you do it. All right. having these folks do it right, and the funny thing about it tonight is you have some of the people that actually helped you stand in the background where everybody else, Jeremy's over there behind the lights there. Do me a favor, tell me, and also the guy hiding over here and pretending he's not here at all is her husband. All right, so come on, join the crime. If you would tell me, to the two of you, what doing this right means to you. I know you're alive, so you get that for a gimme, a freebie.
Right.
But it makes a huge difference. Them doing a good job. You tell me what that means.
It means everything because I'm here with my family. I mean, I have my life back. I'm here with my family, and Orange EMTs are awesome. I mean, they still continue to be awesome because I still have a couple things I'm going through, and they've just saved my life time and time again.
We have got to see Sharon quite a bit, and even though I take no credit for this because I was asleep in bed when this happened to you the first night. We've met, as you've kind of made a habit of doing strange things over the last little while. We have met, and the family we've come to be, I think, probably fairly reasonable, friends over this, to the point to where I'm sort of glad her husband. I've been in Sharon's house with her when he's not there more than should just be allowed. It's just so he's very understanding. But he knows I'm there for the right reason. Jeff, give me your Reader's Digest version of what this did for your family.
It gave me a second chance to celebrate my life with my wife.
Wow. You can't beat that, can you?
Every
in one
day.
sentence. You're more eloquent than I. Can you? Here, we'll swap. You stand over here. You do all the talking. So there you go, folks. Thanks, Jeff. Thanks, Sharon. Everybody, give them a round of applause. You don't get to see many of these.
Well, I think that's a great perspective. And, sometimes we look at patients and we talk about 12 lead that you did, but I think a story like that always makes us remember that every patient that we take care of is someone's wife or husband or uncle or grandma. And you'll see me refer today as how I talk about grandma. And I think that's why we do these things, because here's somebody that's obviously has died, and now you're alive. And that basically sums up care. And certainly this isn't a STEMI, but the reason we put this in here is because it reflects upon the power of what EMS can do. Certain times it really makes a difference. So I think that's a fantastic story. So here's another one. And this is another real one. Mr. Williams, I think we have a little story about Mr. Williams. Is that right?
We do indeed. Mr. Williams is here with us, and this is one of the other stories that we talked about earlier on, where doing lots of 12-lead ECGs just because you have a little suspicion. Mr. Williams saw us all one day, and in fairness, you can probably describe yourself that day, and when you and I talked, you didn't describe yourself as terribly sick. You weren't that typical ashen gray, the whole thing. And this is his 12-lead. He goes to the hospital, and he's an overachiever. He manages to have 2 cardiac arrests before he gets to the catheter. This man's an absolute overachiever. If you would, stand up for me and give us your Reader's Digest version of the events that you have. I'll give you this.
Of what happened
To you that day and what it means to you, the work that Peter and the other guys did to you.
Well,
did it well.
I got a card from my niece up in Northern Virginia, and she said, Uncle Eddie, on the card it said, Uncle Eddie, I heard you had a heart attack. I'm glad you're still here with us. So that says it all right there. And that day, my arms hurt, my chest hurt, but it was nothing major. And I actually walked into the ambulance and got on the cart, so it wasn't anything that knocked me to my feet. I mean, off my feet. And I even went and took a shower and figured that would help. And then I got a little nauseated, and I said, I better call the ambulance. And that's what I did. And then Pete showed up, and he read it, and he says, we got to go to the hospital. So that's what we did.
He's a smart guy.
Oh, yeah.
Smarter than your average bear.
Yeah, thank you very much, yes.
How's that smoking habit do it for you?
I don't smoke at all anymore.
Really?
Heck no. I don't.
Yeah, there you
that's
go.
enough to do.
How many did you smoke before this happened?
About a pack a day.
Yeah. How long did it take? How long did it take you to give them up?
Right then and there, the next day.
Was it worth it?
Yeah, absolutely.
You think so?
Right.
Absolutely.
Right.
So that's a cool story. This is another one of these, but it's a patient who just didn't match the textbook. You just Somebody wouldn't have picked you out and gone, oh my gosh, this man's having a heart attack.
Right.
Until later on, and you end up dead.
Yep.
Twice, overachiever. There you
There
go.
you go.
All right, my
Okay.
friend, thank you. Sit on down.
19 years old, heartburn in the ED. Maybe out drinking a little bit, getting worse over time. What are the odds that a 19-year-old male is going to have a heart attack?
Does he have any unsavory habits like
Several.
cocaine? Okay.
Cocaine,
Well,
heroin.
Then my suspicion would be higher.
Okay. Here's his 12 lead.
Make a decision, folks. Look
In fact,
at the information. Make
you only
a
get
decision.
3 more seconds. 1, 2, 3. Okay. Where's the STEMI? Everywhere. Yeah. So do you know why this guy was 19 and he had a heart attack? He's adopted. Didn't know that his family had familial hypertriglyceridemia and his triglycerides were 1,471. So again, 58-year-old male, no prior history, pumping gas at the 7-Eleven. Maybe he's thinking about driving away without paying for it, whatever. He got dizzy en route to the hospital because he did actually call EMS. And here's his 12 lead.
Everybody's pushing at the one time. There has to be consensus here.
Yeah. Don't look at the top, folks. Ah. Interesting, huh? No docs in the room. But 96% of us got it right, and the other person said something urgent. See? So most of the time, the reason lesions like this don't get reperfused is because someone doesn't do the 12 lead. And this is a classic case. You've got elevation in 2, 3, AVF. You've got depression in AVL. You've got reciprocal changes over in the other leads. And it actually says up top, inferior infarct.
It's a hint. It's a hint.
There you go. So if you can read, you can do it. So look at this. Not bad. They got this guy out of the gas station. They did the 12 lead. They called it in. The cath lab was ready. The wheels didn't stop in the ER. They slammed in some aspirin and some heparin. 19 minutes door to balloon, right? But the real important thing is that total recognition to reperfusion was only 51 minutes. So moving on, another young guy, 24-year-old male, no history of illness, says I never get sick, just have a lot of pain when I cough, coughing a lot, and yeah, he's been snorting a little cocaine. Here's his ECG. Understanding that he uses a lot of cocaine, and those of you that know cocaine is not good for coronary arteries, is it? This is a case that came through our ER about several months ago. So we said 2/3 STEMI, 1/3 not STEMI, and other urgent. So no STEMI. Yeah, he's got a left bundle, right? So not everything that's ST elevation is STEMI. Sometimes it's hard. But left ventricular hypertrophy, and he's just starting to widen out into a left bundle, kind of gives you that look. And the only way you can tell the difference is looking at a lot of STEMIs, right? 38-year-old heavy smoker comes into the ER. He's got tightness in their upper chest and radiating to the neck and jaw. He gets short of breath. And here's her ECG. Looks in tough shape. What are you going to do about it? You going to punch the cath lab button on her?
You got to make a decision. This
You going to
is
mix
the
up some
whole
lytics,
thing.
some Drano?
Make a decision and stick with it.
Not a STEMI? Other urgent? Okay. Half and half. So if we're not sure, what do we do? Yep. Okay, and now she's in your hospital and she has this. She looks bad, but her ECG is not a STEMI. For now, right? So if she continues to look bad, what do you do later? Yeah, that's what they did here. Now, what do you see? Okay.
Same patient.
Oh, you just gave away the answer. You're fired.
If you got a prize,
Yeah, we don't get 100%
if you got a
on this
prize, I
one.
want it back. We're taking your prize back.
All right, so let's see what we think. Okay. We're teachable. So
We
where's
are
this?
a bunch of risk takers here.
So where's the STEMI on this? This is actually a trick question.
The elevation that I see is in lead 1, lead AVL, and there's depression of V4, V2, V3, AVF.
All over the place. All right, did you all see that early on before he pointed it out? The elevation. So this is actually an example of the most commonly missed STEMI presentation, and that is a fairly isolated lateral elevation, because you rarely see the elevation in your far lateral leads like you do in the big tombstone region here, right? We're all familiar with tombstones. But when you have an isolated lateral infarct like this, sometimes people miss it. Only 7% of STEMIs are this. But repeat ECGs, reciprocal changes, y'all looked at this and said this is a bad looking ECG. So remember and be aware of the isolated hidden far lateral infarct, right? This is usually a significant lesion. What's the best way not to have a second heart attack? Yeah. Take care of the, die from the first one. Yeah, that's that is the only permanent way not to have another one.
You don't get a prize for
that. I was going to say, you either get no prize or 3 bags. But taking care of a heart attack. Quit your smoking, treat your cholesterol, exercise. Why does exercise protect your heart? Yeah, it forces your heart not only to get stronger, but it forces it to grow new blood vessels, right? That term we used in med school, angiogenesis. A little bit of low oxygen makes your heart grow new blood vessels. So, here we talked about too many beers the night before. So much for his clean new life, but no one's perfect, right? Okay. So a 76-year-old woman living alone. How many 76-year-old women living alone do you guys pick up? Yep. Most of them get them to the hospital, and, I feel weak. Weak and dizzy grandma. Right? Here's weak and dizzy grandma's ECG. 10 seconds. Been weak and dizzy. Yesterday she was weak and dizzier than the day before. She's chronically weak and dizzy, but she called you tonight because something was different about her weak and dizzy. What do you think? Okay. Anybody want to take a stab at reading this? We all think it's a STEMI. Most of us.
Any takers?
Any takers?
No. Going once, going twice. Valerie.
All
did you
right.
volunteer, or did she volunteer you and you have no idea what's going on?
Okay, absolutely. So inferior. So 2, high. 3, high. 4, high. Depression in the AVL, some depression over here. Once I point that out, right, it's very obvious, and obviously most of you picked it up. And remember this, it's the corner over here, the peanut gallery. And then across from the peanut gallery, AVL. So if you see this characteristic elevation in all those 3 leads, and then depression in AVL, 94% of the time when you see this and somebody has symptoms, it's an acute MI. Bill Brady. You guys don't know Bill? I think he's forgotten more about ECG interpretation than I've ever learned. And I remember as a fellow learning that from Bill. So remember that. You see that constellation. Here we have it again. 40% of the STEMIs that come through your EMS bay will be inferiors. Remember reciprocal changes. Moving on, chest pain. Sometimes that's all you get.
It's
There it
the
is.
guy who died from the first heart attack.
All right. Well, chest pain. All right. See. STEMI or not? Everybody agree this is a STEMI? No, it wasn't. When they cathed this person had clean arteries. That's what they wanted to know.
Don't we all?
So is this a false activation? Ah, so you guys are learning. See, this is a lesion. This is an activation without lesion. Because the patient had symptoms that an ECG that 95% of the time is a block, and they got cathed and they had no block. They just were lucky. It could have been inflammation, or it could have been a Takotsubo's, or it could have been a vasospasm, or it just could have been this is their normal ECG, and they had pain and got cathed. So the important point is that even if this was a activation without lesion, it was the right thing to do.
Clearly, most of what we're talking about, these people will have a lesion. They'll be, if we see these things, they will. But there are plenty of things that anger your heart and give you abnormal tracings that don't actually have a blockage in them. And I think that's important for people to realize. And I think one of the things that you can do and cause a problem is you start to overanalyze this, the 50 different rhythms you were taught in school, and by the time you're finished, you have convinced yourself out of a STEMI. It becomes one of those missed STEMIs. If you think it's a STEMI and your gut tells you it's a STEMI or tells you there's something wrong with it, go for it. Do it. Otherwise, you're going to end up with one of the people that are missed and have a very bad outcome.
Just a little STEMI intelligence. As you probably are aware, only 1/3 of myocardial infarctions show up on the ECG. That's why we call them STEMI, ST elevation. How do we pick out the other 2/3? Yeah. Use serial biomarkers. Just because it's not a STEMI doesn't mean they don't have an infarct. And the only way you can find out if they don't have an infarct is to bring them somewhere where they can get serial blood tests and get watched and get serial ECGs, right? So just because it's not a STEMI doesn't mean it's not an infarct, right? And sometimes we overlook that. Here's typical. You have lazy kids, or maybe the kids just don't want to mow the grass, but there was this person and they had some chest pain because their son wouldn't mow the grass. How many of you had sons that don't mow the grass? How many of you were sons that never mowed the grass? Okay, we got some honest folks here. All right. So here's the ECG. STEMI or not STEMI?
Make a decision, folks.
Make a decision.
All about making a decision.
Mowing the grass. Son wouldn't mow the grass. Now I'm mad. Now I hurt. Here's my ECG. Okay. Yeah. So it's actually not a STEMI. It's a left bundle. So this person has cardiac disease because obviously something's widening out their conduction time, and that's how you get a left bundle. So instead of going from right through the wire, it has to go cell to cell, right? So you have an extended time of depolarization. So that's what makes this wide. We used to call new left bundles STEMIs and take them to the cath lab. We're realizing that we should be more selective. So if this patient looked really bad and you called this in and said, I've got this guy that looks bad, and he has a new left bundle, or he has a left bundle because you may not know it's new, you might end up taking this patient to the cath lab. You may call in and this patient doesn't look too bad, and they may wait and not auto-activate the cath lab, and the patient might be fine. So again, that really talks about the importance of that communication with the accepting facility, because sometimes they're really easy, and sometimes they're not. Okay, moving on. Our diagnosis is chest pain, plus nausea and vomiting. So chest pain, nausea, and vomiting. And, oh, by the way, I missed my dialysis, and I'm just feeling bad, and I have a lot of chest pain. And here's their ECG. Little old grandma, Miss Dialysis, has chest pain. What's going on? Heart rate of 42. Okay. Survey says Not STEMI, 42. STEMI, 8%. Other urgent, 50. What's going on with grandma today? Yeah, hyperkalemia, right? Classic. Very, very, very peak T waves. Changes in her PR interval. Sometimes knowing what to look for makes it easier, right? How many of you, when I said the words missed dialysis, perked up? You guys all started nodding your heads, and now you were looking for this. So sometimes knowing what to look for is really important. So what's the treatment for this? Yeah, calcium, stabilize the membrane, glucose, some other things, and then get grandma to dialysis, right? So not always easy. She was having chest pain and it was really bad. Could you maybe talk me into saying that's the first hyperacute T wave of a very, very early infarct, only seen in 17% of STEMI cases? Sure. But your money would be hyperkalemia in this lady, and indeed her K was 9. So not STEMI, but something just equally as serious. So.
Okay, folks. That's about it for the STEMI Showdown. We got a lot of people that we're going to thank for tonight. Obviously, Dr. David Burt, everybody who came and participated in it, the patients that were good enough to come out again and tell their story. Obviously, our well-recognized lady, Miss Burns, in the background here. The sponsors that we've had and you've watched earlier on, EMS World and Life Care Medical Transports. We hope you've enjoyed it. We'll do another one next month. Thank you. Goodbye.
So my question has to do with there are simple EKGs, simple STEMIs to be able to pick up, but when you have something like a left bundle branch block where it's wider and you have your paced rhythms, is there a simple way for us to be able to tell if there's actually a STEMI going on during the left bundle branch or a paced rhythm?
So there are various interpretive rules out there, and we used to think that if you had a new onset left bundle, that until recently the guidelines actually were to call that a STEMI analog. But just recently, for example, we've looked at new left bundles and LVH, and we realized that the majority of them, even if they're new or the patient's having symptoms, are not STEMI, and these patients don't necessarily benefit from taking them all to the cath lab. So a little bit of it is we're getting more and more careful about what and who we take to the cath lab in terms of left bundles and LVH. If somebody has the paced rhythm, they can be a little more difficult to interpret, and sometimes join the 50-50 club, flip the coin and you're right half the time, right? And you won't even get agreement on these folks from cardiology. But again, what we're talking about here today is 85 to 87% of STEMIs out in the field.
How well is that rhythm actually perfusing with the left ventricular hypertrophy and the bundle branch block?
So when you start to look at left ventricular hypertrophy and left bundles, actually most of the time they're perfusing quite well, unless their other vitals are unstable. So if their pressure is 60/40 or their ultramental status, then they're probably not perfusing. But in general, the ECG finding here doesn't necessarily indicate somebody who's at higher risk of a bad outcome or a problem, unless their clinical condition at that time suggests it.
My question was that most, or I guess a lot of times in the field, I'm saying, I'm just in EMT basic at the moment. A lot of times I'm saying people going on just 3 leads and 4 leads. What percentage of, I guess, index of suspicion would you find that would show any kind of STEMI where they would say, okay, now you need to go on a 12 lead?
That's actually a really good question. I'm glad you brought that up. That the reason we ask you to do a 12 lead is because a 3 or 4 lead done in the field doesn't give you the accuracy to be able to interpret, in many cases, ST elevation, because you need a fixed baseline to compare elevation to, right? And you've probably seen that bringing a patient into the ER where they might have ST elevation on the monitor, and then you bring them into the ER and they hook them up and do a diagnostic 12 lead, and it's normal. So that's why I actually call it a diagnostic 12 lead, because if you're trying to call ST elevation or not, 3 or 4 leads just don't give you the information that you need.
Going off some of the stuff we talked about earlier on whether or not to transmit or call, these things when we're recognizing left bundle branches and paced rhythms that are symptomatic or not for a cardiac event, is that something you want to see, be it transmitted or talk to the person in the field?
Good question. Depends on who's working in the ER, right? But it shouldn't, right? You know, have you guys ever ran into what I call ER doc grouchitis? Call something in and we're a little bit grouchy. That's going away. So we talked about earlier about STEMI used to be a cardiology disease, and then it turned into an ER disease, and now it's an EMS disease, meaning we're pushing the decision-making into the front line. So when you do that, sometimes you're going to make decisions that turn out to be not STEMI, right? But what we're really looking for today are the obvious ones. So if you do a 12 lead and it looks suspicious, call it in and talk about it with the doc. And if you can transmit, that's great, but education is more important, because you've seen today that the vast majority of us here are interpreting these ECGs just fine. And notice we're not calling these into a doc, right? Now these are basic ECGs. Sometimes your patients are going to be a little more difficult. But let's get the easy ones done and then move on to that. And the great thing about ECG interpretation is you can be as good as you want to be, right?